Comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health DocTalk. Real conversations with physician experts from the largest healthcare system in the Maryland, D.C. region. March is Colorectal Cancer Awareness Month. Colorectal cancer is the fourth most commonly diagnosed cancer in the U.S. and the second leading cause of cancer deaths. Yet, this cancer can be prevented with screening and is highly treatable when detected early. The American Cancer Society estimates that over 150,000 people in the U.S. will be diagnosed with colon and rectal cancer this year in 2025. And, unfortunately, over 52,000 of them are expected to die from the disease. Welcome to MedStar Health DocTalk. I'm Ryan Miller, and I'll be your host for today's episode. Today, we're focusing on colon cancer, everything from symptoms, stages, causes, and treatment. We are here with Dr. Walid Chalhoub, the Division Chief of Gastroenterology at MedStar Southern Maryland Hospital Center and the Co-Director of Advanced Endoscopy at MedStar Georgetown University Hospital. Dr. Chalhoub sees patients and families with abdominal issues. His areas of special interest and expertise is in diagnosing and treating pancreatic and biliary disease with advanced endoscopic techniques. Thanks so much for joining us on MedStar Health DocTalk.
Thank you so much for having me. Thank you, Ryan. This is actually a pleasure. I look forward to talking to you about colorectal cancer and awareness. It's very important that we actually bring patients and people's attention to it because, as you said, it is a leading cause of death for Americans, and now it's more prevalent in the younger population, and we'll touch on it more during our talks. And that's why it is very important that we make sure that patients are very aware that it's a real disease and it happens to anybody, and it can happen to both males and females. It can happen to anybody of any race. And the most important thing is that it's happening more in younger people. And that's why I just need to make sure that we bring attention to all that.
We're so grateful for you to help us do that. And to hear that it's so high up the rankings is alarming, but it's good to know it can be treated when caught early. So to take our listeners back, how did you end up choosing a career in gastrointestinal cancers? And what would you say your role is in helping diagnose, treat, and manage them?
My journey into GI was driven really by a very deep interest in internal medicine initially, and particularly in disease of the digestive system. GI cancers, including colorectal cancers, are among most of the most challenging and impactful conditions we see. And they often present silently in early stages, and then making early detection and intervention very crucial. GI always made sense to me, and colon cancer in specific is just because such a silent disease, I thought I would delve deeper into it. And then other than just colorectal cancer, I went even deeper to do advanced endoscopy. That was my focus, and my role really extends beyond the diagnosis to prevent and treat. I perform colonoscopies to screen for and to remove precancerous polyps. I also do advanced endoscopy to look at biliary tracts and the pancreas to make sure that nothing's going on there as well. There's different modalities. My expertise in advanced endoscopy allows me to offer minimally invasive interventions as well, such as EMR specifically in colon cancers. If it's a big polyp, we can take it out. And then obviously other modalities such as endoscopic ultrasound too.
For those who don't know, like myself, what is the difference between colon cancer and colorectal cancer? Are they the same?
Colorectal cancer is the umbrella that includes both colon cancer and cancers of the rectum, both of them. So while they're grouped together due to similar causes, risk factors, and treatment approaches, they are distinct. In a way that colon cancer originates in the large intestine and typically has different surgical and treatment considerations compared to rectal cancer. Rectal cancer occurs usually in the last few inches of the digestive tract, which is the rectum, the very last part of the colon, and usually requires more specialized treatment just due to its location near very critical structures in the pelvis and the anus. So both cancers typically develop from precancerous polyps, which can be detected and removed via colonoscopy, and making screening a very powerful tool for prevention.
Is colon more common than rectal cancer?
No, they're both pretty much very much prevalent in the same way because the polyps do originate both in the rectum and the colon.
When it comes to gastroenterology, Can you walk us through what is gastroenterology versus advanced gastroenterology?
So gastroenterology is the medical specialty focused on the digestive system, including conditions affecting the esophagus, the stomach, the intestines, the liver, the pancreas, and the biliary system. So it covers a wide range of diseases, from acid reflux and irritable bowel syndrome to liver cirrhosis and inflammatory bowel disease. The difference between advanced endoscopy takes an expertise a step further by incorporating highly specialized procedures that allow us have more precise diagnosis and minimally invasive treatment. And these include EUS, which is not something done via a general GI consult. This is more of an advanced gastroenterology consultation. It provides like detailed imaging of the pancreas, the bile duct, the digestive tract, detect tumors, and to guide biopsies as well if you're putting in a needle from the inside of the lumen for you to actually identify the structure on the outside of the lumen, because endoscopy is intraluminal, so you need to identify structures on the outside, and that's how you do it with ultrasound. And once you identify them, you can put a needle inside that structure and biopsy and sample it. And that's done by advanced endoscopists. Also, another very important procedure we do in advanced endoscopy is something called ERCP, which is both used to diagnose and to treat conditions of the bile ducts and the pancreas, such as gallstones, strictures, malignant strictures, cancers. And then the last thing is EMR, which is endoscopic mucosal resection. And we use this specific technique in taking out larger polyps or masses from the actual colon, as well as something called endoscopic submucosal dissection, which is a very new field in GI that's very dynamic, very evolving. As well, it's kind of a endoscopic surgical procedure where you go very deep into the wall of either the esophagus or the stomach or the colon and try to take out masses that prior were always taken out by surgeons. Now we can do this via endoscopic techniques. And that is a whole field of advanced gastroenterology versus general GI. It's just more training for you to be able to do all these procedures.
You all can offer that at MedStar Health Gastroenterology?
Correct. So we have a separate fellowship. So after you finish your general GI fellowship, we have a whole year of training in advanced gastroenterology, and that's what I co-direct. Teach them how to do ERCPs and EUSs and EMRs so that they become advanced. It's a whole year of separate training for you to be able to do that. Actually, we're one of the only programs in the country now that only does it in 1 year because it's such an extensive field. And it, again, as I told you, is very dynamic. We're one of the only programs who still do it in 1 year. We try to focus on it in 1 year. We probably need to extend it to 2 just because of all the different techniques that they need to learn. And I don't think 12 months is enough. So we're working on possibly extending it in the next couple of years to it becoming 2 years, which is now the common thing in the United States for you to train in it.
That's exciting to hear that you're training the future in these services.
I've always been very into academia, and I love teaching doctors how to be a better version of themselves and a better doctor. So, I mean, who am I to judge? But at the end of the day, I try as much as I can to help them do what they do best, and that's advanced gastroenterology, yes.
Wonderful. What are some common colorectal cancer symptoms or signs it's time to see a doctor?
This is what's very tricky. Everybody asks me that question. Patients need to know that it's a silent disease, because it's intraluminal. It is within a hollow structure, so it has time to grow and grow and grow without you feeling. And once you feel it or you feel the symptoms of it, most of the time it's too late because it had time to grow enough that now it's obstructing your colon or it's already traveled to other parts of your body and it's metastatic disease. But very important things that we need to look out for and not take lightly in any symptoms we have, specifically in changes of bowel habits, specifically if you get constipated or you get diarrhea or the caliber of your stools narrows down. These are things that you need to be very aware of. If they change, obviously. Any change in your bowel habits, don't take lightly. This is
blood in the stool, things like that?
Correct. So blood in the stool is a different category. So first of all, we start with a change in bowel habits. So if you go from constipation to diarrhea or you just become suddenly constipated or the change of your caliber of stool changes, that's one. Another one is blood in the stool. Blood in the stool is never normal. If blood comes out of an orifice that it should not come out of, I'll be as crude as possible, then there's something abnormal going on and it needs further investigation. So a lot of people say, oh, you know what? No, it was just when I was wiping. You can think that, but you need to investigate it. What your age is, never take it lightly. Say, oh, I'm in my mid-40s. I don't think it's... No, you need to investigate. And that's where a lot of people go years just, thinking it's normal for them because they're scared or they just don't want to seek medical attention. I think that is something we need to work on. And that's why I think this podcast is very important because we need to bring awareness to these patients that is never normal and they need to go ahead and seek treatment or just a consultation. Unexplained weight loss, because cancers in general make you lose weight just because of the amount of energy they consume from your body and the amount of nutrients they use in terms of sugars for them to grow. And that's why if you lose weight tremendously, that's never normal, unless you're actively trying to, but still if you're not trying. So unexplained weight loss is a huge red flag that we need to make sure that we watch. And then things like persistent abdominal pain, not just any random small abdominal. If you have persistent abdominal pain or cramping that just doesn't go away over weeks, you need to investigate that. That's never normal. Being fatigued or weak, just because anemia, because these polyps tend to bleed sometimes. They don't have to pour blood out, but they tend to ooze very slowly over months or years. And that constant 24/7 oozing does cause you to become anemic, and this anemia causes this fatigue or this weakness. So any fatigue or weakness that is unexplained needs definitely a GI investigation as well. And then the feeling of incomplete evacuation. You go to the bathroom and you feel that you can't let go of your stools, just it's different than constipation. Constipation is you just can't go. But if you do go, but then you just feel that you have the sense where you have not evacuated completely, that's a very high reason for you to investigate that further, because rectal lesions specifically can cause that type of symptom.
What do you feel the need to go very frequently?
Yeah, that is one as well, but it's the sense of incomplete evacuation. That is when you feel that you're not done after you're on the toilet. And that is something that you need to make sure you investigate. Again, like you were saying, urgency and frequency goes with change in bowel habits. So yes, that goes under that category. So anything that changes your bowel habits, where you're going 5 times a day or not going at all, so that's change in your bowel habit, and that warrants a colonoscopy or further investigation of what's going on with you, yes.
And by the time you see the signs, it could be too late, which is why when you hear these guidelines of when to get screenings, do not take that lightly.
At all. And you also asked me if family history could be a risk factor. Family history is a significant risk factor. It is a huge risk factor, specifically if it's in a first-degree relative, like a parent, a sibling, or a child. And if they had colorectal cancer, especially at a younger age, your risk does increase significantly, and you may need to begin screening earlier than the general population. So the general population now, back in the day, when I used to train, it was 45 for African Americans and 50 for all other races. Just because we have seen that the incidence, I told you, it has grown significantly in the younger population, all races have been brought down to 45. And that is just the general population. We're not talking about patients who have a family history. Patients with a family history, you start at 40 or 10 years younger than the youngest person in the family was diagnosed. So let's say your brother, God forbid, was diagnosed at 43. You need to make sure that you get your first colonoscopy at 33, 10 years younger than the youngest person in your family got diagnosed with the cancer. So those are the guidelines that we need to stick to and make sure that we don't change at all.
And make sure you're relaying that information to your doctor during your appointment.
For sure. Yes. So anybody who hits the age of 45 in general from their primary care physician, or sometimes they don't have a primary care physician, need to make sure that they do consult with a gastroenterologist. Every human on the planet needs it. There's no exceptions. There's no race, there's no age, there's no color. It does not see any of that. Colon cancer does not. It just affects everybody. And that's why everybody at the age of 45 with no risks, that's the general population, needs it. So regardless of wherever you are, you need to get your colonoscopy at 45 years old.
Thank you for breaking that down for us.
I just wanted to also mention there are other inherited conditions such as Lynch syndrome or FAP, which is familial adenomatous polyposis. These are patients that have this genetic predisposition that greatly elevates their risk. And those patients also fit into a whole separate category that need to be screened earlier and more frequently as well.
Couple years ago, Chadwick Boseman, he was the star of Black Panther, and he unfortunately died of colon cancer back in August of 2020. He was only 43. And African Americans,
very unfortunate.
They are more likely to develop and die from colorectal cancer. Do we know of any factors that contribute to this?
So the higher incidence and mortality rates in African Americans are influenced by multiple factors. Number one, it's delayed or lower screening rates due to disparities in healthcare access, and that is a known fact. So that's the number one. Number two, the higher prevalence of risk factors such as obesity, diabetes, and diet, and then our diets that are high in processed meats and low in fiber. That's a whole separate thing that would also put us at a higher risk of developing it too. At a lower age, obviously. And then biological differences that make colorectal cancer more aggressive in African Americans. And then socioeconomic factors, including healthcare access, like I said, insurance coverage, and medical mistrust. Those are 3 huge components of why African Americans have higher prevalence of developing it. So raising awareness and ensuring equitable access to screening and early intervention can help address these disparities.
I saw some recent data from the American Cancer Society that shows colon cancer is now the leading cause of cancer deaths in men under 50. Among women under the age of 50, it's the second only to breast cancer. Not so long ago, it ranked 4th in that group. Why do you think more people are being diagnosed with colon cancer now than a few years ago?
Yeah, that's also a very important question, Ryan. As I said before, there's several trends that are driving this increase. Dietary changes. Number one, people are just becoming, I'd hate to say it, fatter. It is. And increased consumption of
I'm guilty of that. Fast food.
Increased consumption of processed foods, red meats, sugars may all be contributing to this on the rise. Number 2 is obesity and sedentary lifestyles. So lack of physical activity and higher obesity rates are known risk factors. Microbiome factors too. So the gut microbiome is a huge new field, not new, but I'd say more, it is kind of a newer field that's been studied. It wasn't studied historically. So now with environmental and gut microbiome, changes in gut bacteria due to diet or antibiotic use or other environmental exposures may play a role as well. And then the delayed diagnosis. So many younger patients are initially misdiagnosed or dismissed, like I was saying before. Like, oh yeah, they'd go like years without checking themselves, even if they saw blood in their stool. They assume that, colorectal cancer is a disease of like older adults, like, why am I 35 and thinking of this, they'd say, like, no, I should wait till I'm 60 or 70 to think of any colon. And that is where the biggest mistake lies. You need to make sure you're screened early to make sure there's nothing wrong with you and continue screening throughout your lifetime because colon cancer is a preventable cancer. And that is very important. Colonoscopies save lives. And I can't say this enough because once you get a colonoscopy, you take out that pre-malignant polyp that if left in place will grow and become a cancer. And it's very easy. You just get it done. You get those polyps out. And I'll talk about the whole process. People are overwhelmed or think too much of it. It's very, very easy. The only time that I say patients hate me is just prepping, which is drinking that prep just to clean your gut out for me to be able to see inside your colon and make sure that you don't have any polyps. But otherwise, it's a breeze. People come here. It's probably the best sleep they've had in their life. For about 20 to 30 minutes, we go in, we make sure everything is okay, and we send them on their way. And if there's anything that's there, like a pre-malignant polyp, we take that polyp out and bring their risk down to 0, which is something that they need to understand. This is the leading cause of death in America.
Right.
And it's totally preventable. Patients need to jump on it and get their colons checked as recommended and keep on the schedule to make sure that they follow through for the end of their life, making sure that their colon is checked.
Yes, thank you for driving that point home. That's definitely the theme of today's episode. So please heed the doctor's advice. You touched on how in the beginning of your career, the screening age recommendation was 50. Now it's 45. Do you know why this is? Do you think it'll go to 40 in the next 10 years?
Probably, yes. Actually, this change was made because of the rising incidence of colorectal cancer in younger adults, and studies have shown that screening at 45 helps detect precancerous polyps and early-stage colon cancer sooner and improving survival rates. So if further studies do show that we need to push it to a younger age because we're having more in the younger population between 20 and 30, yes, be it. Why not push it down to 40 for sure? Yes. I'm a huge proponent to it.
Great. And what are your thoughts on colonoscopies compared to at-home screening kits such as Cologuard? Is one more effective than the other?
This is a very important question. And probably I'd say 80 to 90% of patients who come to my clinic ask me that question. And I'm very biased towards colonoscopies, not because I'm a gastroenterologist, just because I follow science, okay? So colonoscopy remains, and I repeat this, the gold standard for colorectal cancer screening because it is both a diagnostic and a therapeutic procedure, both. So it's something where you diagnose, you see the polyp, and you can act on it right away, all right? And it is the only test that can do both at the same time.
You're seeing that in real time, right?
Oh, for sure, yes. So unlike at-home tests, a colonoscopy allows us to detect and remove polyps before they actually turn cancerous, right? Effectively preventing colorectal cancer. So just like you were mentioning, the screening kits such as Cologuard or the FIT test that you get done at home, FIT stands for fecal immunochemical test. And that is one of the oldest tests known that are non-invasive, they call them, or just something that you do at home, are non-invasive, again, options, and that can detect cancer but not prevent it, number one. So they will congratulate you and tell you, oh, congratulations, you have cancer, The whole point of a colonoscopy is to never get to the point where congratulations, you have cancer. It gets to where, oh, I see this, I'll take it out so that you never get to the point where, oh, you have cancer. You see?
Right.
So Cologuard is very highly specific and sensitive in detecting colon cancer. It is not highly sensitive to detect polyps, which are the precancerous lesions. The whole purpose of a colonoscopy is to catch the polyp before it becomes cancer and take it out. Nobody wants to come and congratulate you that you have cancer. It will tell you you do.
Sure.
Right? But then I think it's too late.
Right. And if you're already that invested in your health that you want to do the at-home screening, you just got to get over that hurdle and do the real thing.
100%. And I cannot. And plus, there's false positives and false negatives with the with Cologuard, and specifically Cologuard can return false positives leading to unnecessary procedures. So they get this Cologuard thing done, and then they freak out and they start getting all these procedures done, and they really don't have it. So a colonoscopy is very, very, very important. And then again, one very important, that false negatives, sometimes you do have it and it gives you a false negative, and that is a crucial point of misdiagnosis, right? Mm-hmm. So you can go thinking, oh, I got my Cologuard test and it said I have nothing there, and like this a huge cancer just lurking inside your colon.
So what is your advice for those, or tips, who are nervous about doing it, who think it's too invasive? Do you have any best practices for someone that they should know before their procedure?
I will tell you one thing. So just for the average risk patient who are hesitant about a colonoscopy, and an at-home a test may be an alternative, those are patients who, if they're adamantly refusing, then yes, because something's better than nothing, right? And then, however, for those that are high risk due to family history, symptoms, or previous polyps, a colonoscopy is strongly recommended like nothing else, So it's mostly patients who refuse a colonoscopy. And I think at this day and age, if you're explaining and you're raising awareness and you're telling patients that everybody gets affected, any race gets affected, younger age people get affected. If you have something, you can tell your children to get screened. So once you tell them that you're actually helping their family also not get it, it would be surprising to me for someone to say no.
True.
At the end of in their sane mind,
right.
If you explain to them the risk factor, that it's a very, very common procedure, the risks are very low to get it. I mean, it's invasive in a way. A lot of people have this taboo with, he's going to go down there. It's something that they need to really think about twice, because at the end of the day, it's a life being saved. Mm-hmm. Really. And if they do have a family history, it's a whole family being saved at this point.
Exactly. And your neighbor's probably done it. Like a lot of people have to do this one day or another.
You know what? A lot of, me and you were talking before we actually started the podcast about a percentage of patients that don't know when a colonoscopy should be done or how. Right. And it's surprising that, it's very important that these programs and going on the news and raising awareness and your primary care physician bringing it to your attention, we have to talk about, and it not be a taboo subject that is not talked about. It is very important that we talk about it and make sure that we raise awareness so that nobody, and again, it's a preventable cancer, so that we bring the incidence down and it not be it really bothers me when we say it's the leading cause of death because it's such a preventable cancer. So the most important thing is they just need to know, just the thought of it is intimidating a little bit. I always tell them it's a safe, routine, and painless procedure that can save lives. I cannot stress this enough. It's safe, it's routine, it's painless, and it saves a life. It checks every single box. So here are some key things that I like to always talk about with my patients, that I say it's painless. Most patients, I say 99% of my patients are sleeping through it due to sedation. And we sedate everybody's, it's like deep sedation. And then many of them wake up saying, oh, that was easier than I expected. Like most of the people that, this is great, or this was the best sleep I had in my life, or, oh, you're done already? It is. And, and that's the most common sentence you hear. Oh, that was I felt like a second. And this is exactly what we want our patients to feel. We want them to feel at ease. We want them to feel that it's quick. And we want them to always make sure that they're screened and come back for the repeat colonoscopies too. We never want to give anybody a bad experience, right? And the worst part, again, I say, is the prep. It's not the procedure. It's just you staying up all night, drinking the prep, because at the end of the day, stool is dirt. And I always tell my patients, if I can create a little pill, people ask me, oh, is there a small pill that I can take instead of the whole prep? At the end of the day, stool is dirt, right? If somebody creates a pill that you put on stool and it makes stool dissolve, I think they'll be a candidate for a Nobel Prize winner and they can retire on some island soon. But it's dirt. And the only way to wash dirt out is a quantity of water. Mm-hmm. And it's very mechanical. You just drink it from above, you flush it from below, and that's the only way to do it.
And you fast for how long?
So you don't necessarily fast. What you do is you go on a clear liquid diet. So you can't eat solid food the day before. So it's just a clear liquid diet all day the day before. And in the afternoon of that day before, you start with the prep. So really, you cannot have the prep or anything by mouth up to 6 hours before the procedure, which is not too bad. So if you think about it at night, if you go to bed at 2 a.m. after you drink and you wake up at 8, you can come get your procedure done in the morning, then you're done.
Gotcha.
So yeah.
You don't have to dive too deep into it, but if you could just kind of walk us through the different stages and what means what once you've hit those markers in terms of the stages.
Yes, of course. So colon cancer is categorized into 5 stages, 0 to 4. So 0, 1, 2, 3, 4. With a stage 0, that means that a polyp has some cancer cells inside of it, and it's called a carcinoma in situ. And the cancer is confined usually to the inner lining of the colon. And the treatment usually is just a polyp removal during colonoscopy via an EMR, the endoscopic mucosal colorectal resection that I was telling you about the advanced gastroenterologists do. Usually these are a little bigger polyps that do kind of just get into the inner lining of the colon, and those need a special technique called an EMR to take them out. There's stage 1. This means where the cancer has grown into deeper layers of the colon, but still has not spread to any lymph nodes. And the treatment usually is a surgical removal of this polyp. So you send them to a surgeon, you tattoo that area endoscopically, and then you send them to a surgeon just to get it out. Stage 2 is when the cancer has spread through the wall of the colon, but not to the lymph nodes again, and treatment is surgery, sometimes followed by chemotherapy. And specifically if there are high features present within the actual polyp itself. Stage 3 is when there is a spread to the lymph nodes, but has not spread to distant organs. So just the area of the colon and the lymph nodes around it. The treatment is surgery and chemotherapy just to prevent the recurrence of it. And the last one is stage 4 when it's metastatic colon cancer. And that's the worst part of it because really the only treatment for it is a combination of chemotherapy, targeted therapy, immunotherapy, and in some very select cases, you do surgery for limited metastases. So let's say you have a lesion in your colon and you see one lesion in your liver. They can get that lesion out of the liver as well as the lesion out of the colon. But again, this is considered a stage 4 cancer, and you need to treat it like a stage 4 cancer.
And this whole point is to not let people get that far.
The whole point is me not even discussing these stages.
Sure.
The whole point is me getting it out before.
Right.
And that's why, again, colonoscopies save lives. If we just remember one sentence out of all this, colonoscopies save lives. 3 words.
And I just wanted to put a button on that conversation. If the results are negative and you don't have any polyps, then you don't have to do this procedure for another, 10 years?
Correct. So if you're the general population, again, it is 10 years. If you have a high-risk syndrome or you have a family history, so depending on what the reason is you're coming to do it, so let's say family history, it goes on a 5-year cycle. Other diseases, it can go down to a 1-year cycle, but still, as long as there is a cycle here to make sure that we prevent it, we're on it.
Gotcha.
But the general population, again, is once every 10 years.
Yeah, so it's not something very frequently.
Not at all. Yeah. Not at all. Yeah, it can save your life.
I think I know the answer to this one after talking to you for a bit, but can colon cancer be prevented?
You bet. So, again, prevented with the fact that if you get the polyp early, it's out. But in general, if you undergo lifestyle choices, the correct lifestyle choice, you don't drink, you don't smoke, you go to the gym, you watch your weight, you watch what you eat, you don't eat processed foods, all these decrease your risk, obviously, of getting it, number 1. And number 2, screening. Screening is the way to do it. So there's only so much you can work around your genetics, but at the end of the day, you make polyps because, as well, it's nothing you did wrong in your life, but you just develop them because you have a genetic predisposition to develop them. And the way to make sure that you come around this genetic predisposition is to screen early and make sure you get those polyps out.
In a recent study, researchers at Mass Gen Brigham in Boston, they found that eating yogurt could help protect against aggressive forms of colorectal cancer. What are your thoughts on this? You just talked about having a healthy diet. Can that really help improve your gut health?
Not only at the Brigham, there's a lot of centers that are actually looking at the microbiome. And the research suggests usually that probiotics in yogurt specifically that you're touching on may contribute to a healthier gut microbiome, which in itself plays a role in reducing inflammation and cancer risk. And the gut microbiome is crucial in regulating immune function and digestion. And an imbalance or a dysbiosis of this microbiome has been linked to high colorectal cancer risk. So like a very gut-friendly diet is something that's probiotic-rich foods such as yogurt, kefir, sauerkraut, kimchi.
Love that.
Yeah. Prebiotic fibers such as bananas, garlic, onions, asparagus to feed good bacteria. And then diverse plant-based foods to promote microbial diversity.
So I think we briefly touched on this earlier, but there was a new National MedStar Health survey. They polled 1,000 people, and unfortunately it found 79% don't know when to get a colonoscopy. What do you make of those findings, and how can we try to correct that?
Yeah, again, that is very unfortunate, and that, like, in itself just bothers me a little bit because we need to spread awareness more. And the most important thing, again, I told you, colonoscopies save lives, and the fact that awareness is subpar, I think. I mean, if you're giving me that number, 79%, that's a huge number.
Mm-hmm.
So that's really 8 out of 10 people don't know.
That's alarming.
Yeah, it is alarming. And that's why, again, things like this podcast, things like people going on the news talking about it, to making sure that you follow with your primary care physician. Primary care physicians' offices being informed that they need to send their patients for colonoscopies once they hit the age of 45, or if they have a family history before, or if they're predisposed to other genetic conditions even before and before. Like, we need to make sure that awareness is very important. And I think as long as we continue spreading this awareness and making sure that patients do, and the access they have. So now, everybody's on computers, everybody's on media, everybody's on Instagram, everybody's on Facebook. If we continue just to make sure that we put this out as a disease that affects everybody and it's a preventable cancer, I think that number should start to dwindle slowly but surely.
What is something you wish patients would ask you that you don't get asked?
How frequently they need to come back?
Yeah, true.
Yeah. So that is a big one, because they think if they've done it once, they're done. And I always insist that this is only one step of the way. And I just become their friend once every 10 years. If the general population we're talking.
Right.
You will see me once every 10 years, but you will make sure that if you do see me, there's science behind longevity of your actual life,
Right.
So you make sure you add years to your life if you screen for colon cancer. And if they get that and they understand that, I think anybody you tell this to with a sane mind is going to go ahead and get it.
True. I mean, they take their car for an oil change when it needs it.
Yeah.
Care about your body the same way.
Yes, for sure.
So, Dr. Chalhoub, why should someone choose MedStar Health for their gastroenterology care?
Number one, it's world-class expertise. So in gastroenterology and advanced endoscopy, not that we're tooting our own horn, but yes,
Toot,
we really do give world-class cutting-edge treatment. Number two, it's a multidisciplinary cancer-centered team. So it's us, the oncologist, the interventional radiologist, the radiologist, the medicine team. So we all work together in a multidisciplinary fashion. We have conferences where we present patients, where we bring these very complicated patients to the table and see how a multidisciplinary approach would bring the best care to them and the best outcome for them. So that is what I think puts us in the leading category of a pancreatico-biliary center, number one, and a gastroenterology and advanced gastroenterology center as well. And then other than that, we have very minimally invasive procedures, so that a lot of patients don't want the big cutting, so we do provide that in advanced endoscopy. And then again, the commitment to patient-centered care. And that again just reflects how we work together to bring the best outcome for them.
What does the future of this field look like? Would you say there's reason for optimism?
For sure. Number one, it's AI-assisted diagnostics. So the new colonoscopes, their new cameras, the new pills that patients are swallowing with cameras, the personalized medicine based on genetics and gut microbiome analysis, just the endoscopic advancements like scarless surgeries and robotic endoscopy, immunotherapy and targeted treatments in GI cancers. If you open new journals, you just read things that are just so dynamic and so evolving. I think it's just a matter of years before AI takes over.
Well, even in the 20 years you've been doing this or longer, you've probably seen a number of these.
Yes. I mean, when I first started training, EUS was very primitive, I'd say. At this point now, for example, interventional EUS is a whole game changer where if somebody had a collection next to the pancreas and called a pseudocyst or just a huge necrotic ball of inflammation, just to put in layman terms, those patients need to go to surgery or just had this with terrible outcomes. Just in the past 10 years, they've created stents that can actually endoscopically drain these collections, and patients really avoid huge, complicated surgeries that before were inevitable. And at this point, we can do they just sleep, they wake up, and they feel instantaneously relieved and better. Not that we're discrediting surgeons, we still need the surgeons in a lot of things, but just they do have an option for a minimally invasive approach, and that has changed.
I can't thank you enough for your time. I have been talking with Dr. Walid Chalhoub at MedStar Georgetown University Hospital in Washington, D.C. Thanks so much for joining us today on MedStar Health DocTalk.
Thank you so much, and I'm really happy that we had the opportunity to talk and to raise awareness, and hopefully we do this more often so that people know more and more about the disease for sure. Thank you so much. Thanks, Ryan.
And one more time, colonoscopies save lives.
Oh, you bet. Colonoscopy. If you do remember anything out of this, a colonoscopy will save your life, yes.